And now we move on to the keynote address. It will be my pleasure to introduce the keynote speaker, Dr. Fasika WORETA from USA. She is the Professor of Ophthalmic Education and Associate Professor of Ophthalmology, the residency program, and the Director at the Eye Trauma Center, Wilmer Eye Institute, Johns Hopkins University and School of Medicine. And she'll be talking to about corneal complications after cataract surgery. Over to you, Dr. Fasika.
Thank you so much, Dr. George, for the opportunity to speak to close the session out. I learned lots from my colleagues. I have no financial disclosures. I'll acknowledge my grant support. So today I'll be talking about common and uncommon complications, corneal complications of cataract surgery. As cornea specialists, still most of what we do is cataract surgery. And as we will see, the theme of my talk is prevention is key. So the most common complication is the Descemet's membrane detachments. We'll also talk about more rare ones like wound burn, and some we rarely see today like epithelial downgrowth. So as I mentioned, Descemet's membrane detachment is the most common complication following cataract surgery. Fortunately, most of the time it is not significant, and it's small at the site of the incision and resolves spontaneously. But the incidence of visually significant DM strips after phacoemulsification surgery is about 0.04%. And from this study that was published in Cornea about a decade ago. And what they defined as visually significant was more than one quadrant of edema and or affecting the visual axis. So when we look during using intraoperative OCT, as shown here, you can see that the incidence of DM strips are actually quite common during surgery. So this was a study that was published in JAMA Ophthalmology. It was a prospective study of about 130 patients undergoing cataract surgery. And you can see here using anterior segment OCT, they imaged for the evidence of DM strips. And basically they found it in 94% of eyes. Most commonly occurred during the step of phacoemulsification, followed by irrigation and aspiration as the second most common step. But again, fortunately, we know that 94% of the time it's not visually significant, so only a small portion of that will be visually significant. So what are some factors associated with DM strips? Blunt blades, if we make a surgeon factor, such as making a long, narrow wound. There are some patient factors as well, such as older age, shallow anterior chamber. And finally, the dense cataract and longer duration of surgery is associated with DM strips. So how to prevent this? We avoid creating long wounds. You can consider using wider incisions for dense cataracts. I always, when I'm teaching my residents, they always want to put their instruments through the large main wound, but I always say to go through the side ports when possible. And finally, when you recognize a DM strip, then you can abandon the use of the main wound and use bimanual, for example, to avoid use. And then for those who do femtosecond laser-assisted cataract surgery, you can see here the anterior segment OCT of the wound, and the configuration is more smooth. And in this study, they found that the DM strips were less with the femtosecond laser. So it was observed in 10% of cases when the wound was made with the femtosecond laser versus in nearly 50% of the conventional phacoemulsification. But importantly, again, the DM strip was self-resolving and did not persist at 1 month in any group, and the visual acuity was the same in both. So how do we manage the DM strips? Well, if you notice it at the end of cataract surgery, and usually if it's more than 1 or 2 millimeters, I'll just leave a small air bubble in. But it's important if you have patients with persistent edema after cataract surgery to think of DM strips and image with anterior segment OCT. And then you can treat by putting air or SF6 gas in the anterior chamber. So this was a study that was published in American Journal of Ophthalmology case reports, where it was 5 patients who presented weeks to months after cataract surgery with DM strips. Some cases required rebubble with air or gas, 2 spontaneously resolved, and 1 did require an endothelial keratoplasty. Moving on to wound burn, which is unfortunately a rare complication. So based on the survey that was done in the Journal of Cataract and Refractive Surgery, the incidence is about 0.4%. So there are some signs when you're going to get a wound burn, such as whitening of the cornea at the incision and milk around the phaco needle. So these were images shared in this publication shown here. So you want to recognize wound burn early and stop, because it can be very hard to manage if you don't recognize. And some risk factors, including using a lot of phaco energy, again, making a long wound, using Helon 5, and if your irrigation there's a kink in your irrigation, so you always need to check before entering the eye. So this is a photo that was a courtesy of Dr. Devkin at UCLA, and you can see this is a wound burn where you can see shrinking of the corneal tissue. So again, these can be hard to suture, often requiring multiple sutures as shown here. You can use a bandage contact lens, and sometimes glue or a patch is necessary in severe cases. Moving on to the complication of corneal melt or perforation. So the use of non-steroidal anti-inflammatory agents have been associated with melts. So you want to avoid these in patients with significant dry eye disease, ocular surface disease, or autoimmune disease. So again, this is an example that was published in AJO case reports of 3 sterile melts after cataract surgery, again in patients being treated with non-steroidals and had a history of autoimmune disease. Wound infections, again, rare, but can happen. So in this study that was published over 20 years ago, you can see the organisms that were the most common, so staph, strep, and 3 of these wound infections were associated with endophthalmitis. So you can see here a infiltrate at the temporal wound, and then in the case number 2, a superior wound with associated scleral abscess and endophthalmitis. Sometimes these do require lamellokeratoplasty and conjunctival flap as shown here. We also see some atypical organisms depending on the setting we're in. So this was a study published out of Bascom Palmer where they had non-tuberculous mycobacterial keratitis at the clear corneal wounds. This was a study this was a patient that was referred to me at Hopkins, where you can see they presented with a wound abscess. There was actually a loose suture here, which I removed, and the patient presented with low IOPE, choroidals, and required a patch graft in order to save the vision. Pseudophakic bullous keratopathy, fortunately, is less common today than in the past due to improvements in cataract surgery techniques and IOL design. So in the US, the incidence is about 0.1%, and globally varies, but about 1 to 2%. So risk factors include dense cataracts, surgical trauma, pre-existing endothelial disease. And most of the time nowadays, we see this not after cataract surgery, but after glaucoma surgery. So this was a patient that was referred to me after anterior chamber intraocular lens placement. So you can see the trauma at the surgical wound, which was enlarged to accommodate the ACIOL. So there's significant scarring, edema, and you can see on tomography the corneal thickness is over 1,000. So this can be difficult to treat, and so again, preventing this is essential. So in conclusion, corneal complications are rare, but they can be potentially devastating. So preventing, recognizing early, and appropriate management is essential. Thank you again for the opportunity to speak, and if you have any questions, my email's on the bottom. Thank you.
Thank you very much, Dr. Fasika, for that overview on the corneal complications of cataract surgery. In fact, we should thank you for coming all over from US and enlightening us on this